Okay, well, welcome back. Sorry about earlier. Um, Found a quiet place to continue this, so I think I'm just going to start from the beginning. We didn't get that far anyway. Um, so the lesson today is on heart disease and cardiac markers, and as I mentioned earlier, before all the banging started, that cardiac markers are uh, categorized into or placed into one of two categories, either acute markers, markers for acute damage, such as screening for acute myocardial infarct, and then those markers that are designed to uh, help assess risk factors for developing cardiovascular disease. So we're going to go through some of the pathophysiology of cardiac disease, um, as well as covering those markers. I'm going to skip through the lesson objectives. You can read those on your own, and we'll just start with this slide here that we had covered, but with all the banging, don't know if, how well you could hear. So these are different terms used to describe cardiovascular disease. CVD, of course, referring to cardiovascular disease, is probably the most commonly used term. Pretty broad umbrella, encompassing both acute and chronic conditions. Coronary artery disease, or CAD, is the term used to refer to diseases of the heart, specifically the arteries of the heart. There are three main arteries, the coronaries, that supply blood to the cardiac muscle. The next term, CHD, or coronary heart disease, it's kind of a double double use of the term heart, because coronary, of course, refers to the heart. So heart disease, or coronary heart disease, not a term that's commonly used, just because it's not really very descriptive. Pretty much the same as CAD. Acute myocardial infarction, or AMI, is the term used to describe when there is a lack of blood flow in the coronary arteries. And of course, this is going to lead to oxygen deprivation and eventually tissue death, or necrosis of the myocardium. Of course, myocardium referring to the heart muscle. Infarction, the term infarction really means that there's a lack of, or interruption of, blood supply, oxygenated blood supply to a particular tissue. So infarctions can happen throughout the body in any tissue. It just means that there's a lack of blood flow to that tissue. And if it goes on long enough, it's going to lead to tissue death. So this is the term that's commonly used to refer to a heart attack. Oftentimes, the lack of blood supply to the heart tissue is due to atherosclerosis of the arteries, or plaque deposits that occlude the arteries. AP, or angina pectoris, is the term used to refer to chest pain that's caused by a decreased blood flow, and thus oxygenation to the heart muscle. The heart is burdened because of the lack of oxygen, but not to the point of necrosis. However, if it's untreated and it goes on long enough, it will eventually lead to an AMI. Congestive heart failure, or CHF, occurs when the heart can't pump out the required blood volume, and this results in accumulation of fluid in the chest. The left side ventricle is usually weakened due to damage from a previous myocardial infarct. This leads to edema of the tissues, especially in the extremities, such as the legs and the ankles. Oftentimes high blood pressure occurs, and this can lead to kidney function decreasing and eventually lead to kidney damage. Stroke is the common term used for cerebral vascular accident, or CVA, and this is where there's a sudden loss of blood flow to the brain, and that can be caused by either a blood clot or hemorrhaging in the cranium. In either case, there's a lack of blood flow, and that's what leads to a stroke. All right, just a little bit about statistics, mainly just to highlight the importance of understanding cardiovascular disease and the accompanying markers that we're gonna go through. Worldwide, there's approximately 17. Statistics are a little dated, so I would imagine it's a bit higher at this point. 17.3, I would say 17 to 18 million deaths per year due to cardiovascular disease. That number is expected to grow to almost 24 million by the year 2030. In 2008, which again, it's been a while, but it accounted for, cardiovascular disease accounted for about 30% of all deaths, and 80% of cardiovascular disease related deaths tend to occur in low to middle income countries. In the US, there are around 375,000 deaths per year, which makes it the #1 killer in the US and worldwide. About 1 in 7 deaths in the US is due to cardiovascular disease. 1 death approximately every 90 seconds. Kind of an impressive statistics there. And then more than about 85 million people live with cardiovascular disease in the US. More people die from this condition each year than from all forms of cancer combined. So really highlights the significance of understanding and diagnosing cardiovascular disease incidence, as well as assessing risk factor for developing it in the near future. So when a physician makes a cardiovascular disease assessment, they take into account several factors, including their patient's health history, their gender, their age, whether or not they have a family history of cardiovascular disease, the patient's weight, whether they're smoking or not, whether they drink or not, their blood pressure, as well as exercise and diet. So, I mean, there's a lot to consider in terms of taking a patient's history to help assess risk factors. When it comes to laboratory diagnosis or diagnostic tests, there's a variety of tests that we have available that also help to give information to the physician about the potential for developing cardiovascular disease in the future. One of the main bread and butter tests, if you will, for helping to assess this is the lipid profile, which really doesn't isn't comprised of a ton of tests. The lipid profile typically will include at least 3 tests. First is the total cholesterol, and then the HDL, which is simply a portion of the total cholesterol. LDL is often calculated, and we'll talk more about that, how that's calculated a little bit later. We do have tests that will measure LDL directly, but it's typically not necessary unless, you'll understand as we go through the different tests. The one that's not listed here, I'm not sure why it's not, is triglycerides, because we can't calculate the LDL if we don't have the triglyceride level. So total cholesterol, HDL, LDL, kind of indirectly because it's usually not measured directly as calculated, and then the third test would be triglycerides. So that's what's required at minimum on a lipid profile. Some other tests that are available to help assess risk factors include BNP, or B-type natriuretic peptide. We'll discuss that. HSCRP, or high sensitivity CRP, homocysteine, and LPA, or lipoprotein A. So these are all tests that we'll discuss individually as we go through the lesson today. All right, first up is myocardial infarction. Of course, this would be an acute event, not a chronic condition. So there's a variety of markers that can help identify individuals who have experienced or a recent myocardial infarct. And some are used more often than others. We'll discuss each one individually, but CK or CPK stands for creatine or creatinine kinase. That's CK. Creatinine phosphokinase would be CPK. They're both the same thing. It's just sometimes we include the phospho, sometimes we don't. Doesn't really matter. Refers to the same marker. And then that's followed by CKMB. And the CK, as is the case with all enzymes, CK is comprised of various isoenzymes or isoforms. And each isoenzyme will catalyze the same reaction, but is slightly different from each other structurally based on the tissue where it's produced. So there's 3 isoenzymes of CK, CKMB, CKMM, and CKBB. If we were to measure each isoenzyme individually and add them together, you would end up with the total CK value. Another cardiac marker that, and this is currently what's the most commonly used cardiac marker to identify acute conditions like AMI, is troponin. And I'll cover troponin in more detail in a minute. Myoglobin is another cardiac marker. It's actually not specific for the heart, but it can be used quite successfully for helping to identify AMI patients. And then the last 2 are more historic markers. They're not used really today, but I'm including them to kind of give you, number one, give you a historical perspective on how laboratory tests for cardiovascular disease has evolved over the years. In addition, sometimes you see questions about these historically used markers on the board exam, so kind of have to address both sides of that coin, getting you through getting you ready to take the board exam, but also preparing you for working in the field as it stands currently. So those are the markers typically used for acute conditions. Congestive heart failure, one of the primary markers for helping to assess risk for CHF is BNP, the B-type natriuretic peptide, which sometimes is also used as a marker for myocardial infarct, especially right after the patient's had a myocardial infarct, but typically used for assessing risk factors for CHF. All right. First up here is creatine or creatinine kinase, CK or CPK. They all refer to the same enzyme. Of course, this should look familiar from when we discussed enzymes several weeks ago. EC 2.7.3.2, ATP, creatine N-phosphotransferase. So as the enzyme commission number shows here, this is a class 2 enzyme, meaning that it's a transferase enzyme. It transfers a phosphate group from ATP to creatine, and of course ATP becomes ADP and creatine becomes phosphorylated, meaning that it's now creatine phosphate. Creatine phosphate is a high energy form of energy storage, and tissues that require a lot of energy to function will typically store a lot of creatine phosphate, because this is the storage form of energy, whereas ATP is what's utilized directly in metabolic reactions. So as the tissue requires more and more energy, creatine phosphate is converted back to ATP so that it's ready to use directly in a chemical reaction. So creatine phosphate is just the storage form and is converted back to ATP as it's required. So if you think about it, what are the tissues that have the highest energy needs? Those would include, of course, skeletal muscle. It tends to be pretty active and requires a lot of energy. Cardiac muscle being the same, and the brain requires quite a bit of energy as well. So these are the tissues where we have almost all of the creatine kinase distributed. So skeletal muscle, brain, cardiac tissue. All right. When it comes to direct measurement of CK, there are two different reactions that can be used for measuring CK activity. The first one we have listed here is called the Tanzir-Gilbarg assay, and it's a triple enzymatic reaction, meaning that if you remember back from when we discussed enzymes, we have to end up with something that we can measure spectrophotometrically, okay? And in this first reaction, neither ATP, creatine, ADP, or creatine phosphate, none of these have any properties of light absorption. So because of that, we have to take one of the products from this first reaction and put it through a second reaction in hopes of producing something that will absorb light. And unfortunately, the second reaction doesn't produce anything that will absorb light. So we put it through a third reaction, and this is the way it works. Finally, this third reaction, because it involves reducing pyruvate to lactate, that ends up producing something that absorbs light, and of course that being NADH. So I have the reagents that would be included in a Tanzir-Gilvarg assay. Had the reagents highlighted in kind of brown here. So the reagent pack for a CK assay would include ATP and creatine, those both being substrates that would be required to produce ADP and creatine phosphate. And then in the second reaction, the phosphoenol pyruvate is included as a reagent, as well as an enzyme, pyruvate kinase. And that, of course, allowing the conversion of phosphoenol pyruvate to pyruvate, or pyruvic acid. And then lastly, NADH and LDH are also included in the reagent pack in order to reduce pyruvate to lactate. So this whole reaction is just like with measuring other enzymes, we're trying to determine the rate of the reaction, or the slope of the line, which indicates the enzyme concentration in the patient sample. Now the enzyme we're measuring, of course, is CK. So the more creatine kinase that's present in the patient sample, the faster this reaction is going to proceed. And the steeper the slope of the line is. Now, because we're measuring the rate of conversion of NADH to NAD, we know NADH absorbs light at 340 nanometers. Since we're going to be measuring a decrease in absorbency over time. So we start out at the beginning of the assay with a very high absorbency, but over time that's going to drop, the speed of which is dependent on how much creatine kinase is in the patient sample. So that's the overall reaction for Tanzir-Gilvarg. Now, incidentally, I don't know if I've mentioned this before or not, but any reaction that includes NADH and or NAD, that you automatically know, of course, that we're going to be measuring that at 340 nanometers. These are assays that are automated. Typically, they're automated. They're not endpoint assays, and they really can't be performed manually on a regular spectrophotometer. And the reason is regular spectrophotometers generally can't measure wavelengths down in this region at this short of a wavelength. This 340 nanometers is pretty darn close to the ultraviolet region, and typical spectrophotometers, unless they have special filters, can't measure wavelengths this short. So that's why typically they are automated methods, and it's not something you want to try to accomplish using a manual method. Next up is the Oliver-Rosalke assay, and I've kind of presented this in the same way as I did the previous. All of the reagents included in the reagent pack test kit are highlighted in kind of a golden brown here. So with Oliver-Rosalke, even though we're measuring the same enzyme, we're just using different enzymes in the second and third reactions. Of course, this is also a triple enzymatic reaction. So the first reaction is the same as we saw with the previous, ADP and creatine phosphate being converted to ATP and creatine. And then the second reagent, rather than utilizing phosphoenol pyruvate like we did with the previous, we are utilizing the enzyme glucose and the enzyme hexokinase. So ATP and glucose, along with hexokinase, is converted to ADP and glucose 6-phosphate, or G6PD, or G6P, I'm sorry, not diphosphate. The third and final reaction utilizes the glucose 6-phosphate and NADP, along with glucose 6-phosphate dehydrogenase, and it actually, G6P reduces NADP, so glucose 6-phosphate becomes 6-phosphogluconate, and NADP is reduced to NADPH. So remembering NADPH, just like with NADH, absorbs light at 340 nanometers, and we're starting off with the oxidized form, NADP. We're going to have essentially a zero absorbency to begin with, and as the reaction progresses, absorbency will increase, the speed of which is dependent on how much creatine kinase is in the patient's sample. So the more CK present, the faster this reaction progresses and the steeper the slope of the line will become. Okay. All right, isoenzymes of creatine kinase. As I mentioned in a few slides back, there are 3 isoenzymes for creatine kinase. They are CKMM, and CKMB, and CKBB. Now, the names of the isoenzymes are derived from the electrophoretic pattern that we get by measuring CK isoenzymes. So I don't recall, I know this is, yeah, I don't recall the specific names for the abbreviations, but the CKMM is the primarily found in skeletal muscle. MB is found primarily in cardiac muscle, and CKBB is found primarily in the brain. And we don't care much about CKBB, but we do CKMB. And what I have, I've itemized really the concentration of CKMM and MB in both skeletal muscle and cardiac muscle, because there you can find both isoenzymes in both tissues, but at different concentrations. So for instance, skeletal muscle is composed 96 to 100% of the 96 to 100% of the CKMM is found in skeletal muscle, whereas 60 to 80% of the CK in cardiac muscle is MM. Okay, so almost all of the CK in skeletal muscle is CKMM. All right, but there's a high percentage of CKMM in cardiac muscle as well. Now, when we look at the MB isoenzyme, about 20 to 40% of the CK in cardiac muscle is MB, whereas there's very little MB in skeletal muscle. Only 0 to 4%, somewhere between 0 and 4% of the CK in your skeletal muscle is the MB isoenzyme. Okay, so we find the 2 isoenzymes in both tissues, but definitely at different concentrations. All right, a little bit about CKMB measurement. Currently, we utilize immunoassays for measuring CKMB, and this is something that is currently used in the clinical lab. We do a fair amount of CKMB assays, and they're measured using immunoassay technology. And as these immunoassays change over time, we name them based on what are called generations. So first generation CKMB immunoassays were utilized measurement of CK before and after inhibition. So we would measure the total CK and then add a inhibitory substance that would inhibit everything but the MB, and actually, let's see, we would measure the total, and then inhibition would inhibition would affect the CKMB. Sorry. So we would just take the difference between the before and after, and the difference would be what is the CKMB. It's an indirect measurement, but would give a pretty accurate value for how much of the total CK was the MB fraction. Currently, we utilize what's known as second generation immunoassays for CKMB measurement, and with a second generation assay, the MB isoenzyme is measured utilizing either an enzymatic method that's specific for MB, or utilizing a monoclonal antibodies tagged with a fluorescent marker or a chemiluminescent marker. And if it's an enzymatic method, we're measuring reaction rate, and the units will be would be units per liter. But if it's a fluorescent or chemiluminescent tagged monoclonal antibody, and that way we're measuring the actual mass of the enzyme rather than the rate of reaction. So the units are different, being either nanograms per mil or micrograms per liter. Hopefully that makes sense. Okay, when you're measuring mass, it's different units than if you're measuring enzyme activity. All right, in this slide here, I have illustrated what we use traditionally for measuring CKMB, and that is electrophoresis. Even though it's not utilized anymore, it does help to kind of illustrate, the different bands, different isoenzymes of CK, and so let's go through those. Right here is where the sample, patient sample, would be applied to the gel, and then when electrophoresis, you apply the current, the bands, most of the bands are going to migrate towards the anode or positive electrode. There is one form of CK known as CKMI, which is found in the mitochondria, that will actually migrate in the opposite direction towards cathode, but we generally don't care about CK, mitochondrial CK. During electrophoresis, the CKMM will actually stay close to the point of sample application. It doesn't migrate very far at all. The CKMB will be in the middle, and CKB has the fastest migration and will travel the farthest. Some patients might exhibit a band between the MM and MB that can confuse interpretation depending on how well it's separated, but this is called macro CK, and it's actually composed of CKBB that is complexed with immunoglobulins IgG and IgA. It's mostly seen in women over the age of 50, but is not of significance when it comes to measuring isoenzymes for as cardiac assessment. Also, there's a band of oh, never mind. I just talked about that. All right. So, in terms of in this illustration here, this slide, I've tried to make the width of the band relative to how much of the enzyme you would normally find in a normal sample. So you would find more MM than MB. Depending on the age and gender of the patient, you may or may not find this macro CK, but if it's present, it wouldn't be present in a large concentration. Neither would CKBB. You wouldn't find that in a large concentration either. CKMB really should be less than 6% of the total CK. If it's greater than 6%, that generally indicates that there's been some degree of cardiac muscle damage. And of course, MM should be 94 to 100% of the total CK. All right, the clinical significance of creatine kinase. Of course, we primarily use it in the diagnosis of AMI, and in that respect, if you take the patient's creatine kinase value and divide it by the number assigned to the upper reference limit, or the upper, the normal range, the number for the highest number for the normal range. If it's greater than 8, or if their value is 8 times greater or more greater than the upper reference limit, it usually indicates a very poor prognosis, because of course the more enzyme present, the more tissue damage has occurred. So the amount of tissue damage required to reach that concentration of 8 or more times the upper reference limit usually means that the patient has suffered a lot of muscle damage and probably is not going to survive. The CKMB rises within 4 to 8 hours, somewhere between 4 to 8 hours after the patient has had a heart attack. It generally peaks around 12 to 24 hours and will eventually return to normal within 48 to 72 hours. So, patients that present to, say, the ER complaining of cardiac symptoms, if their symptoms and their history match having likelihood of having had a heart attack, then oftentimes they'll be admitted for observation for at least 24 hours, and we'll draw their blood about every 8 hours and measure the cardiac markers, including CKMB, every 8 hours, so that we can check to see if, if initially they have a normal CKMB, but they have had a heart attack. Usually within 8 hours of admission, we'll see an increase, the beginning of an increase in the CKMB. In patients that have experienced some type of muscle damage, skeletal muscle damage, either acute muscle trauma, as would be seen with like a motor vehicle accident, or if they have a muscle disease condition such as muscular dystrophy, you're going to see an increase in the CK, the total CK. In both of these cases, trauma and muscular dystrophy, you're going to see an increase in the total CK. You'll probably see an increase in the CKMB, but it's not going to be a significant increase of MB. Okay, it'll be less than, definitely less than 6%. We can also see increase in total CK in patients that have central nervous system disorders, such as stroke, because of course the BB isoenzyme is produced by the brain. All right, next to cover is something called the CKMB index. And remembering that an index is simply a percentage of a value when compared to the whole. All right. The CKMB index is easy to determine. We can calculate it. Sometimes it's called the relative index, but in either case, you use the total CK and the CKMB, and you just simply divide the CKMB by the total CK, multiply it by 100, and that number should be less than 4%. Okay, because remember, the amount of CKMB in muscle tissue is anywhere between 0 and 4%, right? So if your index is great, 4% or higher, usually indicates that a good portion of the MB is coming from myocardial tissue and not from the skeletal tissue. Okay. All right. Reference ranges for CK in reality are gender dependent. Males tend to have a little bit higher upper reference limit for CK than females, simply due to differences in muscle mass. So oftentimes for CK, it's for men, it's anywhere between 50 and 160 units per liter. Women, it's just a little bit lower, 50 to 130. I don't think most places don't have separate reference values for men and women, because really the difference between 130 and 160 is not that big. If you consider the range, the range for the normal reference limit, 15 to 160, it's pretty wide range. So that being said, the difference between 130 and 160 is not really that big. So most labs just set one reference limit for both men and women. Just keep in mind, in reality, it's probably a little bit different. The relative index normal range, relative index or percent CKMB should always be less than 3.9%. Anytime it gets higher than that, it's likely due to some degree of cardiac damage. We can utilize either serum or plasma for CK measurements. Incidentally, the enzyme is slightly light labile, nowhere near the degree that that bilirubin is, but over time, the longer it's exposed to light, it will decrease in activity over time. You definitely want to avoid hemolysis because it will cause positive interference, meaning that hemolysis will falsely elevate CK values. If it's not going to be analyzed right away, I really want to refrigerate this so that enzyme activity is preserved. All right, a little bit of a case study here before we move on to the next marker. We have a couple of guys here, Leroy and Buck. They're driving home after a long day of cattle branding. I don't know how I came up with this one, but work with me. Both these guys, they're driving home, same car. They're involved in a car accident, and they're both taken to the local ER. Both men complain of chest pain, and cardiac enzymes are measured for both. The total CK is 560, and the MB is 34 for Leroy, who is driving. Whereas the CK Buck, he has a total CK of 4,800 and an MB of 6. So, if you can just consider the numbers for both patients, everything is high, making you wonder, wow, did they both have a heart attack? What exactly is going on? But if you calculate the index for both patients, you'll find out there's a big difference here. Oop. Didn't even do that. Go back. Oh, it's not letting me go back. Good Lord. All right. Well, you'll just have to look at the handout that you have. If you calculate the index for Leroy, who was the driver, his index is 6.1, which is suggestive of an AMI. Whereas if you calculate the index for Buck, who's the passenger, his is only 0.1%. So, yeah, likely, Leroy probably had a heart attack and caused him to have the accident. The reason why the passenger, Buck, would have a high CK is likely due to muscle damage from the accident itself. But of course, most of that is coming from CK-MM and not from CK-MB. Okay. All right. So looking at this slide, historical cardiac markers, we have LD or lactate dehydrogenase, LD or LDH, right? And AST. LD used to be measured pretty frequently. For assessing cardiac damage, we still measure this enzyme, but not as a cardiac marker. Okay, it's just it doesn't give the same kind of information that we get from other markers. There are 5 isoenzymes of lactate dehydrogenase. LD1, 2, 3, 4, and 5, and normally in someone who has not had a heart attack, there is more LD2 than there is LD1. Okay, so there's a higher concentration of D than 1. However, in patients who have had a heart attack, we see that this pattern is flipped. So in patients that have just had a heart attack, their LD1 is going to be greater than LD2, which is great. It's a reliable marker, but the problem is how long it takes us to measure those isoenzymes. The assay is a lot longer. So because we have more specific and quicker tests that give us the same information, this particular test is kind of fallen by the wayside. As for AST, or aspartate transaminase, if you recall from the liver lecture, this is an enzyme found in the heart, liver, skeletal muscle, and the kidneys. And the tissue with the highest concentration of AST is actually the heart. But because it has the highest concentration of the heart, it used to be used to help assess patients with an AMI. But again, we have better tests that are quicker and more accurate than measuring AST, and so it's used right now. It's used primarily just as a liver enzyme. All right, let's go through what happens in terms of markers when they rise, peak, and return to normal. Looks like my graph's a little off here, but you're still going to get the same information. So on the y-axis, we have the degree of elevation, or the multiples of the upper reference limit, and then on the x-axis we have days after onset of the AMI, and we're going to look at these three markers. But the one I really want you to pay attention to is the CKMB. Okay, so CKMB begins to rise 4 to 8 hours after an AMI. It tends to peak around 12 to 24 hours, and it remains elevated up to for 2 days or 48 hours. Whereas AST doesn't begin to rise until about 6 to 8 hours. It peaks 18 to 24 hours and can remain elevated around 5 to 6 days. Lactate dehydrogenase will begin to rise 12 to 24 hours after a heart attack, peaks 48 to 72 hours, and will remain elevated after, long after a week, so around 10 days. A couple things I want to mention here, since we're looking at when these enzymes rise. This is an important factor to consider when you're looking at enzyme data or cardiac marker data. The sooner we can identify whether someone has had a heart attack or not, the sooner they can receive intervention to help minimize long-term heart damage. Okay, and I'm mainly talking about thrombolytic therapy, such as streptokinase, urokinase, tissue plasminogen activator. These are all medications that have thrombolytic activity and will break down blood clots and help restore blood flow to the affected tissues. Now, those medications are not without their risks, and so anytime you're using a medication that has thrombolytic activity, there's definitely a risk for hemorrhaging, and it can be quite severe if not monitored very carefully. So what we've come to realize, what we've come to learn, is that the risk-benefit ratio is affected by how soon the thrombolytic medication can be administered after someone who has had a heart attack. And if it can be initiated within the first 4 hours of symptoms of a heart attack, then the benefits outweigh the risks for using thrombolytic activity. After 4 hours, that changes pretty dramatically. The risk of hemorrhaging outweigh the benefits that would be achieved using thrombolytics. So, looking at these three markers, it's pretty obvious that the best one is CKMB, but it's definitely not perfect. I mean, it begins to rise at the end of that window, that 4-hour window. And potentially you're not going to see a rise until that window is closed. And then if you look at AST and LD, these are definitely markers that are not going to be useful to help determine whether thrombolytics should be administered or not. So just wanted to point that out. So, having said that, in comes our next marker, which is troponin. Now, troponin is a protein that is it's actually a complex of three proteins that bind to the thin filaments of striated muscle, and that includes both cardiac and skeletal muscle. But not smooth muscle. So we really don't see troponin in any tissues that are comprised of small muscle, such as, or smooth muscle, sorry, such as the GI tract, for instance. Okay. What it does is, hold on a second here. I got ahead of myself. So troponin is a complex of three different types of troponin. We have troponin C, we have troponin T, and we have troponin I. And you can kind of see where each one is located in relation to actin and myosin. Okay. Troponin C, its function is to bind calcium. Of course, calcium is required for normal muscle activity. So when troponin C binds calcium, this results in a change in the troponin complex, a conformational change, a change in structure, and that allows for the muscles to contract. Okay? Troponin T binds to tropomyosin and helps to position the troponin complex along the actin filament, keeping everything aligned correctly. And then lastly, troponin I regulates the contraction by preventing binding or interaction of myosin and actin. Okay, so those are the three different forms, and a little bit about how each one functions. Now, troponin C, there really is no difference. There's no significant difference in troponin C that's found in cardiac muscle versus troponin C found in skeletal muscle. So because there's no measurable difference between those two, we can't utilize troponin C as a cardiac marker, because it's going to be elevated regardless of whether it's coming from the skeletal muscle or from the cardiac muscle. However, there is a difference, a measurable difference, between troponin T and troponin I that's found in skeletal and cardiac muscle. So because of that, we can utilize either one of these to help determine the source of the damage, what type of muscle is involved. All right. I blew the punchline, but that's fine. We've already talked about the function of these three here, so I'm not gonna rehash that. We'll talk about the cardiac troponin I and cardiac troponin T. So that's, just to abbreviate that, CTNI and CTNT as cardiac troponin I and cardiac troponin T. Um, Cardiac troponin I, essentially there's about 13 times more cardiac troponin I than there is CKMB in cardiac tissue. So there's much more troponin I than CKMB, um, making it a better marker for cardiac damage than CKMB. And troponin I begins to rise after an AMI. It begins to rise anywhere between 3 and 6 hours. So that's better than 4 to 8 hours. It gives us a little bit more, a little wider of a window in terms of determining whether thrombolytic therapy would be beneficial or not. Troponin I levels tend to peak between 14 and 20 hours after an AMI, and they don't return to normal until 5 to 10 days after the first symptoms have appeared. So they peak early, they rise early, they peak early, and they remain elevated for a long period of time. The reason it's important to consider how long they remain elevated is not all patients will seek treatment immediately after experiencing symptoms, because the symptoms are so similar to, say, acid reflux or heartburn. You know, sometimes GI symptoms can be confused with cardiac symptoms. There are patients who are a little hesitant about, going to the ER when it could be, what they're feeling could be nothing more than some kind of, gastrointestinal upset, but for some of those patients, a day will pass, or several hours, or a day or two. Eventually, they may talk themselves into, well, maybe I really do need to get checked out. So, if it's a day or two later, or 3 days later, with the other markers, that might not be able to determine whether, yeah, you had a heart attack. That window for diagnosing that may have passed. Whereas with the cardiac troponins, especially troponin I, if it remains elevated up to 10 days, there's a higher likelihood that we can determine, okay, yeah, you had a heart attack. Even though they can't be given thrombolytics, knowing that they've had a heart attack can help reduce the chance of them having future heart attacks by addressing some of the underlying causes. All right. Normal range for troponin I is 0.1 to 3.1 nanograms per milliliter. Okay, and that's the general range. It can be affected by the type of assay that's being used, but generally, 0.1 to 3.1 is going to be pretty close to what's considered normal. Cardiac troponin T, very very similar to, has a lot of the same properties that cardiac troponin I has. It's a very sensitive indicator of tissue death and necrosis, cardiac tissue death and necrosis. It's actually more sensitive than troponin I is. And it begins to rise within 3 to 4 hours after a heart attack. So it tends to rise, quicker than, or not. That doesn't have the same potential for rising a little later than troponin I does. Tends to peak within 10 to 24 hours, so kind of similar to troponin I. returns to normal within 10 to 14 days, so it does remain elevated for a longer period of time. And the normal value for troponin T is anything less than 0.1 nanograms. So it's very specific, very sensitive, even more so than troponin I is. The real disadvantage to utilizing troponin T, however, is it can be falsely elevated in patients that have renal failure. And there's no law that says you can't have renal failure if you have a heart attack. You definitely could have both. And I've seen it working on the bench. I've seen patients come into the ER with elevated troponin T values, because that's what we measure. And they look at their history, and they have a history of renal failure or renal disease. And that's kind of a red flag. You need to interpret those results with caution if the patient has kidney disease, because there's a potential for a false elevation. With troponin I, you don't have that. You don't. We don't see false elevations of troponin I in those same patients, but with troponin T, you can. So that's something to be aware of. Okay, so the review: cardiac troponin T rises 3 to 4 hours after the AMI, peaks at 10 to 24 hours, remains elevated for 10 to 14 days, a bit longer than troponin I. Allows for both early and late diagnosis of AMI. It's highly specific for cardiac damage, much more so than enzymes, any of the enzymes, but of course not 100% specific. In reality, there is no 100% specific marker for cardiac damage, but some are obviously better than others. It is useful in monitoring effectiveness of thrombolytic therapy. So as you can see in this slide, if you take the cardiac troponin T level on the first day, divided by the cardiac troponin T level on day 4, if that value is greater than 1, if they've received thrombolytic therapy, that value is greater than 1, that indicates good success for helping to restore cardiac function and helping to minimize long-term muscle damage. If that number is less than or equal to 1, that's not so good. That generally indicates poor response to therapy. Okay. All right. Cardiac troponin I. My slides are out of order here. So cardiac troponin I rises, as mentioned earlier, rises 3 to 6 hours after the symptoms of AMI have presented, peaks around 14 to 20 hours, remains elevated for 5 to 10 days. So kind of similar to troponin T, not quite as good, but pretty similar. Allows for both early and late diagnosis of AMI, just like troponin T. It's highly specific for cardiac damage, more so than CKMB, but not quite as good as troponin T. Troponin T really, between the two, is more sensitive. And like I mentioned earlier, it's 13 times more abundant in heart tissue than CKMB. So it's really what gives it its high sensitivity. All right, so reference ranges. Not sure why I have. Yeah, it's for troponin T or troponin I. Troponin T, it should be less than 0.1 nanograms per mil. Same as it's similar as if you're using micrograms per liter. It's less than 0.1. Troponin I it really should be. I'm not sure why I have this here. Maybe cut and paste error. It should be 0.1 to 3.1, not less than 0.1. So go ahead and make sure you make that correction. 0.1 to 3.1. Let me. Nope, can't. Gosh darn it. That's why I don't like recording these lessons. For some reason, it doesn't let me go back. Wish I hadn't done that. Anyway, if you still have that last slide in front of you, ignore this one. I'll wrap up the other information. So just remember, cardiac troponin I, the reference range should be 0.1 to 3.1. Cardiac troponin T and cardiac troponin I offer comparable information, except that, with the exception that troponin T, between the two, troponin T is more sensitive and is usable. Well, it depends on where you work. I'll just leave it there. Okay. The one drawback, probably the major drawback for utilizing troponin T is, like I mentioned, patients that have renal failure or kidney disease, they can have a falsely elevated troponin T level. Both are measured using enzyme immunoassay. So either enzyme-linked immunosorbent assays or chemiluminescent assays. It just depends on the manufacturer. And the sample can be serum or plasma. So that makes for easier sample analysis if you can use serum or plasma. All right. Next is myoglobin. So myoglobin is similar to hemoglobin in that it binds oxygen in a similar way. But the function of hemoglobin is to transport oxygen to the various tissues, whereas the function of myoglobin is to store oxygen in muscle tissue. Okay. Tissue distribution for myoglobin, primarily skeletal muscle and cardiac muscle, because these are two of the tissues that have the highest oxygen requirements. The brain does as well, but the brain doesn't have myoglobin, doesn't have that option. It needs a constant supply of blood supply to deliver oxygen. Reference range for myoglobin is a little different between men and women, anywhere between 30 and 90 nanograms per mil for males, and generally less than 50 nanograms per mil in women. And again, serum or plasma can be utilized, but it's essential for myoglobin that there is no hemolysis, because the assay for myoglobin, hemoglobin can cause positive interference. Okay. All right, the measurement, just like what we saw with the troponins, measurement is immunoassay, typically enzyme-linked immunosorbent assay. The clinical significance is that myoglobin elevates very early. You'll see myoglobin begin to rise within 1 to 3 hours after a heart attack. But it also peaks relatively early as well, 5 to 12 hours, and then returns to normal in under a day. So it peaks fast, but it returns to normal very quickly as well. So it's a good early indicator for AMI, and can really help with determining whether thrombolytic therapy should be used or not, but it can also be falsely elevated in people with kidney disease, just like with troponin T. It can also be elevated in patients that have any type of skeletal muscle damage, whether it's trauma or some type of other condition like muscular dystrophy. So it's kind of it has really good points and it has really bad points as well. Another advantage of myoglobin is that it's a good indicator for determining reinfarction. For instance, if a patient is already in the hospital, they're already hospitalized because they've had a myocardial infarct, and they begin to have more cardiac symptoms, and the doctor suspects maybe they've had another heart attack on top of the one they just had. Myoglobin can be a good marker to measure since it may have already cleared after the first event. So because it does clear so quickly, it can be used again to help assess whether they've just had another heart attack or not. All right, so let's take a look at these current markers, just like we did with the historic ones. And CKMB kind of straddles both worlds because it's not utilized as often as it used to be, but it is still something that is performed. We still do them where I work, so and I know other facilities do as well. So we have them kind of aligned here based on when they begin to rise, peak, and how long they remain elevated. Myoglobin being the most sensitive and first to rise with cardiac damage. At 1 to 3 hours, peaks 5 to 12, returns to normal within about a day. Troponin T, followed by troponin I, and CKMB. So just kind of a nice graphical representation of comparing these different cardiac markers. All right, well, let's shift gears just a little bit and talk about markers for more chronic conditions, such as cardiovascular disease risk assessment. And as we saw in one of the, early on in the lesson, there's a variety of tests that can be utilized. Probably the most standard one that's utilized most often would be the lipid panel, which would include total cholesterol, HDL cholesterol, oftentimes a calculated LDL, but it's something that most labs can measure directly now. And you definitely need the triglyceride value incorporated into that lipid panel. And then also BNP or B-type natriuretic peptide, high sensitivity CRP. There's a regular CRP that we can perform, but if you're going to use it as a risk assessment for CVD, you want we need to measure what's called the high sensitivity C-reactive protein. It's not really, there isn't a difference between the two proteins. They're both the same protein. It's just when we measure regular old C-reactive protein, the assay that we use has a much higher threshold for what's normal than the high sensitivity. So it's really how much are we measuring? Okay, when we perform a high sensitivity CRP assay, we're measuring a much smaller amount. Okay, C-reactive protein is an acute phase reactant. So when there is any type of inflammation that's occurring in the body, you're going to have an elevation of CRP. It's just that if it's due to, for instance, if it's due to someone having an infection, you're going to have a big increase in CRP. That's normal. If it's due to chronic low inflammation, you'll have an increase in CRP, but it'll be a very small increase, and it'll be lower than the amount that we can normally measure with just a regular CRP assay. So that's really the difference between the two. Is just how much how low we're able to measure. Homocysteine levels is also something that can be measured to help assess cardiovascular disease. We'll get to that in a bit, as well as LPA, or lipoprotein A. Okay, so first up is we'll talk about the BNP, or B-type natriuretic peptide. The B stands for brain type natriuretic peptide, and it was first discovered in pigs, and they call it brain type because they identified it first in the central nervous tissue of pigs. So that's just simply where it got the name brain type. It's a hormone that is actually secreted by the ventricles of the heart, and its main function is to help regulate blood volume. And when you regulate blood volume, you indirectly regulate blood pressure. Okay. The way this works is by this hormone BNP is produced by the ventricles in response to higher blood pressure or high blood volume. So when the blood volume or blood pressure gets too high, it will stimulate the ventricles to produce this hormone, which will affect the kidneys by, it stimulates them to increase the excretion of sodium in the urine. And I'm sure you learned this in urinalysis, that where sodium goes, water follows, right? So if you increase the excretion of sodium, you also increase the excretion of fluid, of liquid in general. So that has the effect of increasing total urine volume, or urine output, which decreases the amount of blood volume and decreases the blood pressure. So not surprisingly, the tissue distribution for BNP is cardiac muscle tissue, specifically the ventricular myocardium. This is a hormone that is measured primarily by using enzyme immunoassays. Now, before I move on, I do want to mention that there is another flavor of natriuretic peptide. We have B type, but we also have A type. All right, and there are other causes, of course. There are other causes for edema, such as pulmonary edema. And in that case, in the case of pulmonary edema, or fluid collecting in the lungs, that doesn't necessarily cause an elevation of BNP, because it's not directly affecting the heart. The heart doesn't really sense a increase in blood volume or blood pressure. Okay, so ANP is the other flavor of natriuretic peptide. ANP stands for atrial natriuretic peptide. And this is released by the atrium versus the ventricles. and it has a similar effect on sodium levels in the fluid, but it does it a little differently. ANP stimulates the release of aldosterone, which acts to conserve sodium when blood pressure is too low. Okay, so it's BNP increases sodium excretion, ANP increases sodium retention. Okay. All right. We don't really care about ANP. That's just kind of a side note. Back to BNP. The clinical significance for this marker is that it's a good marker to identify or diagnose CHF, or congestive heart failure. All right. Patients with BNP levels greater than 20 picomoles per liter or greater than 100 picograms per milliliter, either unit, these patients have a higher probability of suffering from congestive heart failure than patients that have BNP levels under those two values. Okay, so if they're high, it's an indication of risk for congestive heart failure. If they're lower, but that's more normal. Okay, BNP. This makes BNP a specific marker for edema, specifically due to congestive heart failure and not other conditions. Okay, it can also be a predictor for coronary artery disease, which may lead to an acute myocardial infarct. All right, we're not going to worry about the picomoles per liter units. Most labs utilize the picograms per mil unit. So reference range for BNP should be just simply less than 99. Okay, anything greater than 100 is abnormal. All right. Next is the high sensitivity CRP, or high sensitivity C-reactive protein. As I mentioned a few minutes ago, this CRP is an acute phase protein. It's not specific for any type of inflammation. It's just it becomes elevated in inflammatory reactions, and its main function is to help promote phagocytosis. So it functions, has an immunological function to help increase the immune response to foreign invaders. Okay? It's a protein that's synthesized in the liver and is produced in response to cytokine production by other immune cells, especially the lymphocytes. So if there's an increased production of interleukin-6 or interleukin-1 or even tissue necrosis factor alpha, all of these cytokines produced by the immune system will stimulate the liver to produce C-reactive protein, which is just another chemical that helps to activate the other cells of the immune system. All right, it's primarily produced in the liver, so of course that's the main tissue distribution. But it is released into circulation, so of course you're going to find it in the blood in patients that have an infection or any other type of inflammatory condition. All right, for clinical significance, it's a reliable predictor of acute coronary syndrome. high sensitivity or high sensitivity CRP indicates high risk for coronary artery disease. Coronary artery syndrome, or acute coronary artery syndrome, indicates some reduction in blood flow to the heart. So the symptoms of acute coronary syndrome they're similar to angina, but definitely not to the degree that you would experience if you're actually having a myocardial infarct. Okay, so very much like angina pectoris. Okay. Atherosclerosis is usually involved or develops in patients that have chronic inflammation. What happens is that macrophages will attempt to repair the endothelial damage of that's caused by plaque formation that develops inside the arteries. And several studies have been shown to link elevated levels of CRP with plaque formation. Okay. The cytokines and enzymes that are released by these macrophages will actually further damage the endothelial lining, and it further exacerbates the plaque formation because as the macrophages are present and release these enzymes, you get this slow deterioration of the endothelial lining, which makes it more suitable for plaque to attach to. So it's really kind of this vicious cycle of repair and further damage and further plaque formation, which is why it's a good predictor for coronary artery disease, because it elevates over time at a very low level because of the activity of these macrophages, and it all contributes to more plaque formation developing in the coronary arteries. The measurement range for these high sensitivity assays can be anywhere between 0.01 to 0.03. And I shouldn't say range, it's the range of the lower reference limit. So I don't recall off the top of my head what the lower reference limit is for, or the lower level for linearity is for regular CRP, but it's much higher than 0.03. And that's really what makes these assays, gives them their high sensitivity, is that they can measure it at such a low level, 0.01 to 0.03. Most of these assays are immunoassays. Some are measured using nephelometry, which we'll talk about nephelometry in a little bit later. Essentially, it's based on how particles in solution scatter light at different angles, but we'll get to that. Reference range for high sensitivity CRP, less than 0.7 milligrams per DL or milligrams per liter, less than 7 milligrams per liter. Either one of those just depends on the lab and the assay that they're using. Homocysteine. Or HCY. Homocysteine is a sulfur-containing amino acid, same as cysteine and methionine. Now remember, cystinuria causes cysteine crystals to form in the urine and makes the urine smell like sulfur. Homocystinuria is a deficiency of the same pathway. All right. Homocysteine is an intermediary in the synthesis of cysteine from methionine. Certain vitamins and folate are also involved in this synthesis. Two pathways, one with vitamin B and folate, and the other utilizing homocysteine. This is why when there is a deficiency of these vitamins and folate, the homocysteine concentration increases because it's trying to compensate. Okay. Homocystinuria is an inborn error of metabolism where there's a deficiency of an enzyme called cystathionine beta synthase. Okay, cystathionine beta synthase. This results in elevated levels of homocysteine in both the blood and the urine. So this is something that was covered in MLT 120, and this can cause mental retardation in newborns and thrombolytic problems that eventually could lead to death. Homocysteine causes thrombosis due to the toxicity of homocysteine to the vascular endothelium. This was based on autopsies in children with homocystinuria who had severe atherosclerosis that was very similar to what was seen in elderly patients. Okay, and that led to studies to correlate homocysteine levels with atherosclerosis. The exact mechanism is unknown, but there are studies relating high levels of homocysteine with atherosclerosis, and thus with the risk of developing coronary artery disease. Several hypotheses are that homocysteine has a direct toxic effect that damages the cell lining inside the arteries. Homocysteine promotes vascular inflammation, and also homocysteine accelerates oxidation of LDL, which is the low-density lipoprotein, the bad form of cholesterol. Okay. All right, for measurement, again, not surprisingly, immunoassays tend to be the most common used, but there are also fluorescent assays that utilize fluorescent tags. Even chromatography can be used for measuring homocysteine, but it's typically immunoassay. Reference ranges can be anywhere between 6 and 11 micromoles per liter, with the risk for developing coronary artery disease beginning at around 15 or higher micromoles per liter. Usually serum is required for this particular assay. Lastly, we have LPA, or lipoprotein A. This is an unusual type of LDL with apolipoprotein A attached to the another lipid, a lipoprotein, which is ApoB100. So I don't really care that you remember that it's attached to ApoB100. It's an unusual type of LDL. Okay, lipoprotein A is usually attached to HDL. Okay, Lipoprotein A is similar to plasminogen, or at least it has a similar activity as plasminogen does. It inhibits the formation of plasmin by competing with plasminogen activators, which inhibits fibrinolysis. So you can see the problem here. Someone who has a heart attack, and if the body is trying to release plasmin or convert plasminogen to plasmin, this can interfere with that process and kind of inhibit the recovery, the natural recovery process. Elevated levels are also associated with having a higher risk for developing blood clots or thrombosis. It's also a good predictor for potentially developing stroke. And it's measured by immunoassays, especially ELISA assays. The reference value for lipoprotein A is less than 30 milligrams per deciliter. All right, my good friends, that is it. Hopefully this wasn't too bad. I will try to get this posted soon, and we'll send out an email as to, with the link where you can find this this lesson. I'm also going to try to make the transcript, the transcript of this lesson, make that available too. So, all right. Until next time. Thank you.